This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, my name is Dr. Robert Page and welcome to Doc Talk. Doc Talk is a series of podcasts that's produced by the Knoxville Academy of Medicine that features Knoxville area physicians and members of the Knoxville Academy of Medicine giving information to patients that's helpful in terms of making their healthcare decisions. And I feel fortunate to have with me today Dr. Ayaz Rahman. Dr. Rahman is a cardiologist who is actually from the East Tennessee area, grew up here, and now works here as a cardiologist with Cardiology Associates of East Tennessee. Welcome.
Dr. Page, thank you so much for having me. I feel honored and privileged to spend some time with you guys talking a little bit about cardiology.
And we're always glad to have people here to give us information that we can utilize and boost our numbers, because so far we're doing pretty good with our numbers, aren't we, David? Yeah, we're doing good. Yeah. So, anyways, apparently this is a very well seen podcast. So, and we continue to give information to patients. I think it's gonna. I think that's something we hope to continue to do. So today we talk a lot about, when we think about cardiology, we think about some diseases that are very common to patients, things like hypertension, coronary artery disease. But you're here to talk to us today about coronary valvular disease. Now, can you give us a concept as to the valves of the heart, how they function, and how something that's gone wrong with these valves can lead to problems for a patient?
Sure. So just basic anatomy of valves. We're all born with 4 valves, and sometimes we can face problems at a young age that are known as congenital problems or problems that we were born with. Those issues are usually picked up in the pediatric or adolescent part of one's life. The types of issues that I typically see are in adults, which can be from various things that can go awry with the valve, such as age-related wear and tear of the valve. So of the 4 valves, there are basically 2 problems that can occur with any of the valves, which is one can be narrowing of the valve, where not enough blood flow can get through the valve. And the other problem is leaking of the valve, where too much blood flow is going backwards instead of forwards. And both problems can be significant for adults, and sometimes, can manifest in different ways. Sometimes patients may feel something significant, such as shortness of breath, particularly when they're trying to exert themselves. They can feel chest discomfort or pain in the chest. That can be anything varied from sharp pains, pressure-like sensation, and it could be even something subtle like fatigue, just not feeling like you have the same level of energy that you once did. And so the manifestation of valve disease can be varied, and so it's kind of important to hopefully try to pick up on that as early as possible.
Gotcha. So not just things that we would associate with the heart, which is center of the chest, and pain, but respiratory issues, fatigue issues, anything that, and this is generally seen in older populations.
So there are some valve diseases that are seen in as a disease as we get older, such as narrowing of the aortic valve, and that's typically seen in patients that are octogenarians and above, so patients that are in their 80s or above. But sometimes these diseases can manifest earlier. So, for example, if you had a disease that required radiation to your chest, like lymphoma or something at a younger age, that radiation can affect the structures inside of your chest, such as your lung and your valves and your coronary or your heart arteries. And there are other things that can be environmental, so things that you are exposed to. We do know that tobacco use can lead to increased calcium buildup on the valves, which can cause narrowing. And then some things are things that you might have had at a young age. So if you had rheumatic fever or a simple infection as a child, that may manifest later in life as a valve problem because of the immune system's way of fighting off the disease that you had as a child.
Gotcha. So I'm a patient. Maybe I have a concern about valvular disease. Maybe I have some of the symptoms you've been talking about. Is this something that I would be screened for by my primary care physician and then generally be referred to you? Or how do patients generally come into your practice?
So I think the first thing is recognition within the patient of the symptoms. So if things are just not feeling right, you know, fatigue, chest pain, shortness of breath, palpitations, you feel like your heart's racing. Your first, you know, your most trusted resource is your primary care physician. And he or she will do some diagnostic testing in addition to just listening to your story and performing an exam in the office. A lot of things you can pick up on exam for valve disease and the way that blood is flowing in your heart. And then simple tests like blood work, chest x-ray, EKG. Ultimately, the gold standard way for us to diagnose valve disease is something called a echocardiogram or a ultrasound of the heart.
Gotcha.
That is a not an invasive test. They just rub some jelly on the chest, put a little probe on, just like an obstetric ultrasound, and we're able to get a lot of information about the function of your heart, how the valves look. Is there a leaky valve? Is there a narrow valve? Are there any abnormal holes in the heart? Or is there any abnormal fluid accumulation around the heart? Things that can kind of clue us into as to what might be going on.
Gotcha. And so a patient's been diagnosed, they end up in your care, and you're concerned about valvular disease. You may have a presumptive diagnosis of valvular disease. What sort of what then do you do for this patient?
So we are fortunate to be a part of what we call a multidisciplinary valve team. And so when the patient gets referred to us as the cardiologist, we try to either make or help the primary care physician make the diagnosis and then confirm the diagnosis. Sometimes confirmation involves performing additional testing, such as CT scans of the heart or MRIs. Sometimes we need to do a heart catheterization where we take a picture of the heart arteries or measure the pressure inside of the lungs to see if the valve is affecting the lung or the right side of the heart. And once we make the diagnosis and confirm the diagnosis, then we usually discuss the patient's care in a conference. And in that conference are cardiac surgeons that perform open heart surgery, cardiac anesthesiologists that help us manage patients during procedures, cardiac imagers that help us interpret some of the imaging studies that might be more detailed than a traditional cardiologist is used to seeing, particularly as it pertains to like CT and MRI. And then once we discuss the patient's case, we then try to figure out what is the best therapy for the patient.
Gotcha. And so this sounds like a very extensive look at the patient, because you're not only you're taking this diagnostic information and then discussing with not only a surgeon, but a cardiologist, a radiologist, an anesthesiologist. You have multiple specialties which are discussing this patient and therefore coming to a therapeutic decision. So if the patient is not necessarily, now of course we're not going to talk about open heart surgery or cardiac surgery. What sort of alternatives would you be able to present to the patient in terms of their therapy?
Sure. So in the past, the only way that we could treat advanced valve disease was one of two ways, and that was through medicines, which we know is a bit of a Band-Aid. It just helps to kind of alleviate symptoms, but doesn't necessarily take care of the underlying problem. And then the other option was open heart surgery, where the surgeon opens up the chest, puts you on a heart-lung machine, and that is obviously of the things that we do in medicine, probably the most invasive thing that can happen to your body. So in the last 10 years, structural heart and valve therapy has really progressed to the point where we can offer minimally invasive options. So minimally invasive options are options where we can fix valves by doing things such as going through the leg arteries to replace a valve. We can replace a valve in the aortic position or even in the mitral position, and that's called transcatheter valve replacement. That's where we deliver a valve through plastic tubes. and wires and things, similar to a coronary angioplasty.
Wow.
And we can also work on leaky heart valves. We have things for the mitral valve, which is a valve on the left side of the body. If the valve is leaky, we can put on clip devices and things without ever having to do any type of incision at all. It is all through the leg vein and the leg artery.
So, the option now exists for, it used to only exist where you could have, if you were going to replace a heart valve, you could do it only if you did open heart surgery on the patient. Now you can actually do that from inside the vessels. You can actually do the entire replacement procedure.
Yes, so we can work on a beating heart while the patient is awake.
Wow.
With minimal sedation. The transcatheter aortic valve replacement has really revolutionized the way we treat left-sided valve disease in the heart. When it was first FDA approved in 2012, it was really reserved for patients that were deemed to be too high risk for open heart surgery. And now the FDA has approved all comers, whether they're low risk or intermediate risk or high risk, as the preferred way of replacing a aortic valve.
Wow. So we're mainly talking about left-sided heart disease, which for patients, this is the part of the heart that actually pumps blood out into the body. And so then the two valves we're talking about are the aortic valve, which pumps it into the largest vessel in the body, and the mitral valve, which actually which pumps it over to the lungs.
Correct. So the aortic valve is essentially the gatekeeper of your heart. It is the valve that connects your heart to the rest of your body. And that valve we can treat successfully with minimally invasive valve therapy. The mitral valve, there are devices that are FDA approved to fix leaks of the valve in the way of something called a MitraClip. If there's a pre-existing surgical valve in the mitral position, we can put a valve inside of that valve from a transcatheter standpoint without having to do open heart surgery.
Wow.
And I would say in the next 3 to 5 years, we will have FDA approved valves for both the mitral position and the two valves, or the tricuspid valve on the right side, to replace those valves fully transcatheter.
Wow. And moving over to the right-hand side of the heart.
Correct.
That's unbelievable. So, just for comparison's sake, if we're talking about a patient who's going in for open heart surgery and having a valve replaced versus doing it via catheterization, what would be the difference in terms of recovery time for the patient?
So the recovery time, the difference is huge. For transcatheter valve replacement, we typically we do a few things. So the reason why we have the anesthesiologist as part of our team is we really like to do the procedure under what's called conscious sedation. So that's without a breathing tube, and that's without general anesthesia. We know from the literature that patients that where you can successfully do the procedure with minimal sedation, they have better outcomes. They don't have the lingering effects of anesthesia. They can get up on their feet quicker, and they can go home quicker. And so we really try to do as little sedation and anesthesia as possible, but to still make the patient comfortable and to make the procedure safe. Typically, the procedure takes about 60 minutes or less, and we monitor the patient overnight, and they get to go home the next day.
Wow, that's unbelievable. And in terms of, so if I'm a patient and I need to have this procedure done, is this something typically insurance will pay for?
Yes. So we have FDA approval. If you have low risk, intermediate risk, high risk, we have FDA approval to proceed with transcatheter valve replacement. There are some, one of the things that we do have to think about, which is why the team comes into play, is if you have a young patient that, say has a problem with their valve that they might have been born with. So like a bicuspid aortic valve, which is a valve that has 2 leaflets as opposed to 3 leaflets. Sometimes those patients have other heart pathology, like they may have an aneurysm or a enlargement of their aorta. And if that's the case, then we really need to think about surgery when they're younger, because we need to fix the aorta and the valve. And so when we look at patients, it's not just the initial procedure that we're talking about. We have to also think about the next procedure, because if they're in their 50s, we expect, whether you put in a transcatheter valve or a surgical valve, we expect that valve to last on average 10 to 15 years. And so for us, it's very important to think about what is the procedure that we are going to be able to offer this patient when they're 70 or 80.
Wow. Wow. So basically, once we have this procedure done, and this would be true whether or not it was surgical or done your way, that these are not valves that necessarily last forever. You're going to have to be in continued care of your cardiologist, and if you've had surgery, your cardiac surgeon. But in a general sense, if we're talking about a patient who's coming in and they're going to have surgery versus transcatheter valve replacement, what would be the difference in terms of recovery time?
So surgery, usually patients are in the hospital for about a week,
Right.
and that first month is a little bit heavy for them.
Right.
It takes about 30 days for the wound to heal in the chest. If you do a transcatheter procedure, we do these procedures at Park West on Mondays and Tuesdays. Typically, patients go home on Tuesday or Wednesday, and by Monday of the next week, they are participating in cardiac rehab. They can
Wow.
exercise, they can go hike Mount LeConte, they can
Wow.
do whatever they want.
That's unbelievable. And this would be, this has advantages not only just in terms of recovery for that, but these are patients who do well to actually continue to be active consistently and not spend a lot of time sitting around, basically causing any sort of pathology to the remainder of the heart.
Correct. Yeah, we see all sorts of patients. Obviously, recovery and rehabilitation time is super important to patients and their families. We recently took care of a gentleman who is the primary caretaker of his wife, and it was very important for him to be able to get back to his wife and to be physically active and in shape. And if we performed open heart surgery, that would probably limit his ability to do things that were very important. So obviously the big things are, the patient's quality of life, their symptoms, and mortality, and we want to improve all of those things. But sometimes, there are other things that are weighing in on our decision making as we make these decisions of minimally invasive versus surgical.
Gotcha. So, Dr. Rahman, let me ask you this. If I'm a patient and I want to discuss with you the possibility, if I've been diagnosed with valvular disease or know I need to have a procedure, how would I get in contact with you or your office?
Sure. So we have a large team, and on that team are folks that are valve coordinators and valve navigators. We have a number that goes directly to them.
Gotcha.
And they take in
We'll have the number down here.
yeah, and take information. But we have a phenomenal team of support staff that help us get some patient information, and if you're coming from elsewhere, to assemble all the diagnostic testing that has already been performed, so that we don't have to repeat anything. And that also makes the first visit more fruitful. We know a little bit about you before we even walk in the room.
And is there a website that maybe patients can go to get some additional information on this?
Sure, we can share our website. There's a website to our structural heart and valve team through the Covenant system.
And the address will be right here.
Yeah, and we'll share that and absolutely provide that for the public.
Most excellent. Well, I was going to say, you certainly have educated me, because these are changes that have occurred. I have very little exposure to cardiology in my practice, and this is something you've educated for me, because this didn't exist when I was in medical school or even in residency early out of practice. And so I think it's important for patients to know about these alternatives that currently exist. They have the number to contact you and to be able to perhaps to have a different way to approach their health care than has traditionally been done.
Yeah, this is really, this has been amazing to be able to provide this to our patients. We feel very strongly in our team that we have some amazing physicians, clinicians, providers, nurses that have trained all over the country at phenomenal places. And I think the one thing that unifies our team is the concept that we want to be able to provide this level of care at a high level locally, so that patients don't have to travel to Nashville, Atlanta, and things like that. And I think we're very fortunate to be a part of a health system that we have the support to kind of continue to provide that level of care.
Excellent. Well, thank you so much for joining me here today, Dr. Rahman.
Thank you so much for having me.
And with that concludes this episode of Doc Talk. Doc Talk is a podcast that's produced by the Knoxville Academy of Medicine and features its physician members giving information to patients, which is helpful in terms of making their healthcare decisions. I'm Dr. Rob Page, and thank you so much for watching.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.